Hello, everyone, and welcome to the Arthritis Action Podcast. My name's Marc, as always, your host, and today I'm joined by Afni Shah-Hamilton. Afni is a consultant fellow podiatrist specializing in pain management and movement, and is here today to give us some insight into podiatry and arthritis, and also a selection of related topics, I'm sure, as well. So, hello, Afni. Welcome to the podcast.
Hi. Thanks, Marc, for having me.
Thank you so much for joining us. I really appreciate it. So, as always, my intros are incredibly brief. So if you could tell us a little bit more about yourself and your work with arthritis.
Yeah. So I previously and still do advisory stuff for Versus Arthritis. So when it comes to their booklets on podiatry, or if there's particular initiatives, I'll review stuff for them. I also work with the Institute of Podiatrists now. So they used to be known as the Institute of Chiropodists and Podiatrists. And I'm on their education board, but I also speak about cancer because cancer and arthritis also are interlinked, because some of the symptoms of stuff that arthritis patients get are similar to cancer patients because of the treatment drugs that they're on, but also in terms of just because you have cancer doesn't mean you're not going to have arthritis as well. So a lot of these conditions are all co-linked. So I have been running my private practice, Tiptoe Foot Care, for just under 20 years now. And it's a podiatry clinic, but also a pain management clinic. So we also look at the whole body and try and figure out when things aren't working, why aren't they working, and have a bit more of a holistic view as well as the medical view. So I suppose it's a bit more, my approach is Western medicine plus Eastern medicine and how they can both work together. And I know with arthritis sufferers, that works really well. So we see a lot of patients, particularly in the pain management side, with arthritis. But again, it's a very common problem in the world of podiatry. So we do that as well. And I also sit for Macmillan on their advisory board for the cancer side of things. So quite well versed in a number of the areas.
Not a big fan of free time then.
No, sadly not. I'm very passionate about what I do. And I think it's important that good information goes out to patients, because sometimes, for whatever reason, whether you're not getting the right advice from the NHS clinics, or they've got the lack of time, or just whispers on the internet, sometimes just some good knowledgeable information and quick tips can really help change someone's life over, especially because it affects the quality of your life.
Absolutely. Yeah, I couldn't agree more. So let's start off really simple with, what does a podiatrist do?
Right. So the easiest way to understand what a podiatrist does, they can treat anything from the lower limb down. So basically, I've categorized it into 4 areas. So we look at the vascular areas of podiatry. So that's our circulation, blood flow, veins, all of that, making sure everything's flowing properly. So that's the first area. And we know, like with rheumatoid patients, they can get ischemia and get vascular issues, but a number of the other arthritis also get affected. We've also got the neurology. So that's all your nerve sensation. So we're always checking particularly for peripheral neuropathies, which is loss of light touch, vibration, hot and cold temperature, detecting that on the feet, and it can travel up to the legs as well. The third area is dermatology, which is skin and nails, which again, as we know, arthritis sufferers suffer from, not only just in terms of mobility, if they've lost hand mobility and trying to look after their feet and their legs, but also in terms, so they can't cut their nails or keep the hard skin at bay or moisturizing, but also in terms of the other skin conditions, because you can get things like ulceration, so breakdown of the skin because of where the deformities are, they're rubbing against the shoe, or there's too much pressure on that area. So we treat all of that as well. And then we've got the musculoskeletal side of things, which is basically your walking cycle, your joints, the movement, the tendons, the muscles, all of that. And as we all know with arthritis, that is all affected. But particularly, it's really important to see in podiatrists because we are looking at those gait cycles. I mean, our knowledge on the foot anatomy and leg anatomy and the gait cycle is immense compared to the other professions, because we have to take into account like vascular disease, neurology, and how the joints work and everything, and all together, put it together and see how that affects the patient in their walking cycle and how that then impacts their mobility. So hopefully that gives you an idea.
It does, yes. Yeah. One thing is where you mentioned, say, like lower limb, is that knee down, and is the knee included?
So it works on the knee, the hips, pelvis area and the foot. So if you've got some kind of foot arthritis going on, let's say actually you've got some kind of knee arthritis, so you can't move your knee or it can't straighten. Once that happens, when you try and put your weight down, it actually affects your hip and it starts to make it tilt more. And then that then affects the further up the body, but also affects the foot because the foot can't move sufficiently. So every time you take your first step when you're walking, which is in every single step we take, your body can't coordinate itself. So pressures where you had just on the knee, you start to get on the ankle, you get in the hip joint as well, but that then travels up to the lower back into the sacroiliac joint and then further up in the spine.
I've had similar things happen to me as well. I had knee pain for like years, and it turns out that my foot was pronating slightly out, which was then causing my hip to have an issue. My hip was too tight, and then the two of them together created loads of pain in my knee, and that's where I felt all the symptoms.
Yeah, and because basically what happens if the hip's not moving and the ankle's not moving, it's like a accordion, right? The pressure point happens at the knee. So the knee's taking all of that pressure. So it's coming from where is the root cause? Does that make sense? And then working around it. So that's our approach in the pain management side of things. Again, with the arthritis, you get joint restrictions happening. So you can't move the big toe. The big toe is crucial in being able to push off on the gait cycle. And if you can't push off, you can't propel yourself. So others have to take more impact in trying to get yourself forward as well. So again, that puts further pressure on those joints and further damage into the area.
That goes in nicely to my next question, actually. I was going to ask like what effect arthritis can have on the feet and the lower limbs as well, as we're now talking about. So you could go into a few more things that it can do.
So in terms of, let's start with the simple ones like the mobility issues. So in terms of just caring for your feet, things like cutting your toenails or being able to file that hard skin down, because if you're not able to do that because of grip issues or just being able to bend down, that can already start to affect how you're walking and how you start to distribute your weight. Because if you can't cut your nails properly, they become painful, they start to get infected. And again, we know with a lot of these autoimmune conditions, your immune system drops, so then you're more susceptible to infection. So you've got the ingrown toenail side of things. So you've got those, and then you've got the corns that develop, which are incredibly painful. It's like walking on a stone every step you take. So then you're trying to avoid that area. So you've got the arthritis, you're trying to avoid that area, and then you're getting new areas of pain because it's a reactive symptom of what you're trying to avoid. So you've kind of got a vicious cycle going on in just terms of what you think is simple mobility of not being able to cut your nails or get back to that hard skin suddenly becomes a much more complex problem. So you've got that side of things. But then you've got the actual arthritis affecting the joint. So say like for gout, you get those episodes of really sharp pain and everything, uric acid crystals depositing in the joint. So again, particularly in the big toe joint, it stops it moving. So again, stops you being able to lift that toe up and down, starts to affect the gait cycle, is another area. With rheumatoid, luckily with the drugs, we're not seeing as much of the kind of classic nodules that you see on the foot with the crabbing of the clawing of the toes. But what you do see is, again, the thinning of the skin, looking at the vascular side of things on there, because again, if there's poor blood flow getting to that area, that's going to have a negative impact. But also just in terms of, you need to have that foot nice and mobile for every step you take, because the terrain that we walk on is very uneven. So, you'll be walking on tarmac and then you're walking on pavement that's uneven. So again, you want that nice, healthy foot mobility going on. But with arthritis, you get the restrictions going on. So being able to adapt and keeping your balance can also become a problem as well. So we've got the balance issues with these conditions, the actual pain of just having to move that joint because it's restricted as well, being painful. You've got your osteoarthritis, which can often come under the umbrella term metatarsalgia, particularly in the forefoot. So it's any joint pains that are happening in that area as well. So, and then you've got the psoriatic arthritis, which again affect the skin, the nails, and you get these sudden swellings in the toes, which again, you can't put your shoes on. So again, footwear gets affected, your walking gets affected, your tendons get affected. All of it just starts to have a whole mushrooming effect on the body.
Definitely, yeah. I mean, it is one of those things. It's always like, so from the ground up, a lot of the problems are kind of caused, aren't they?
I always kind of say it's like a Jenga tower. We're born with a lovely, perfect Jenga tower, most of us, nice and straight. And throughout the years, we get tiny little knocks going on. And as you know, whenever anyone plays Jenga, when they take out a block or they move a block, it starts to become more and more unstable. It doesn't matter what the cause of the instability is. but it does become unstable. And then that's when you start seeing the weaknesses, and that's when you start to see those pain episodes happening. And so I always try and describe to them, it's like a Jenga tower, and you're getting all these knocks, and we're just trying to keep that Jenga tower nice and strong for you.
That's a great analogy. I like that one. I'm probably gonna steal that one, just so you know.
That's fine. As long as you credit me for it.
I'll do my best. I'll do it. So how are these problems diagnosed then? So how would you diagnose a foot or an ankle problem?
So there's a few different ways. So clinically, you come and see us, we look at your joints and go, because of our knowledge and how we assess the joint, we're able to diagnose, actually this is feeling a bit arthritic, this feels more like the symptoms you're coming in with feels like more of a rheumatoid arthritis problem or a gout or a psoriasis problem. But also you've got the clinical tests as well. So you've got things like MRIs, ultrasound, X-rays as well, and then you've got your blood tests as well. So sometimes, say someone is coming in with a symptom of rheumatoid arthritis, often they'll have 3 different joints swelling rather than just one particular area. And then we'll be like, that's looking more like a rheumatoid arthritis case. Let's get some bloods done for you to check whether you've got the rheumatoid factor, your ESRs and things like that. So you've got a number of different things, but also I do stress on, it's really important to have that clinical background, and knowing, understanding, and getting that really good patient history of what's going on. Things like gout, again, you get these flare-ups with gout. Again, it's that uric acid level increase. So that would be a blood test, but you'd be coming in and seeing us and we'd go, right, this area is hot and swollen. But you're also looking at the clinical signs, this sudden change in the joint happening overnight kind of thing. And also we'd be looking at things like, we know with gout, particularly it's diet related as well. So asking them things like, what's your diet like, and things like that as well, to give you that good clinical picture to go, it's never just a blood test or it's never just a X-ray, because if you X-ray one of us as we get older, there's probably are areas where we've got wear and tear of our joints, so technically that's an osteoarthritis, but that doesn't mean that's stopping you doing everything you want to do. It's just we all have that little bit of osteoarthritis in us just inevitably as we get older, but it's the whole clinical picture and how that's operating.
I remember being told that before as well, because I've got it in my lower back, and I remember when they sort of showed me the X-rays of it. Go, to be honest though, if you X-ray anyone's back, they've probably got some form of this anyway.
That's
it's just
exactly
you don't notice most of the time.
Yeah, and also with X-rays or any of these clinical imaging things, is there is a snapshot. They're not looking at how the joint moves. So in my pain management stuff, yes, patients do have arthritis in the back, particularly in the sacroiliac joint right at the top between L5 and S1. But equally, let's look at whether the pelvic position, so your pelvis is meant to be nice and straight, and then your spine goes nice and straight above. But if your pelvis is slightly tilted, you know that you're going to get a compression on that side. So yes, you are going to get a wear and tear. But if we can get that pelvis to straighten, again, takes away the pressure. Yes, you'll still have that area of wear and tear, but you've taken away the pressure, you've taken away what's causing you the issue. And again, that could be through identifying the pelvis, and then the foot's not moving or the knee's not moving, giving you an orthotic if you need. Although the thinking is now changing about orthotics as well, and also how we use them. So it just depends on what's going on.
How so is the thinking changing?
So in my pain management side, they're starting to look at, actually, we all need a tripod stance. So basically, when we stand on our foot, we need to make sure the first and fifth metatarsal on the heel are on the ground. And so it gives that nice triangle, nice stable. Often, if there's a patient who there's a restriction going on, the first metatarsal, so say the rheumatoid patient has a bunion, so the big toe, so it's the big toe that kind of goes basically like a triangle. And if that's going on, you've lost your nice stability points. Does that make sense?
Yeah.
So, and the 2 key areas you need to have that 3 stability points is when you supinate, so you get that nice arch shape, and when you pronate, which is when the arch flattens. So the theory is that if you can't do a good pronation, so people saying, oh, I've got flattened arches, but if you can get your finger under the big toe joint, actually you're not truly pronating because you've lost your nice stable tripod grip. Because in the gait cycle, the pronation part of the gait cycle is when you first land your foot on the ground. It has to be nice and mobile, and it has to have that 3 stable points in order to absorb shock. If it can't do that, it starts to go up into knee and hip. So they're saying now that if you can't pronate correctly or supinate correctly, you're going to have issues. And sometimes if you get given a rigid orthotic, because they're saying you're collapsing your arch, but you're still not making that good point of contact for pronation, which allows that nice supple mobility in the joint cycle to allow that shock absorption, you can start to see how that can have a negative impact further up the body because you've lost that shock absorption, and that then impacts your knees, hips, and spine. So that's the latest stuff that's coming out, and that's the stuff I do. There's more information on it on my website, but particularly there's a few different people who advocate it. One in particular is someone called Gary Ward in Anatomy and Motion. So he talks about the gait cycle in that way. But there's loads of stuff about talking about how the gait cycle works and what we should be doing. And in terms of an orthotic, if you do get an orthotic, you don't want something rigid, because you do have to, in our cycle, go from a supinated arched foot to a flattened pronated foot. And then vice versa. It goes back and forth like a pendulum as we're walking. And if you're stopping any point of that cycle, the rest of the body can't rearrange itself to help support it. Does that make sense? So you're then having these issues that come about. And this is where I think we do need to look at more and be more aware of doing good joint assessments, particularly in the foot and the way the foot is assessed, as well as the knee and the hip. And by knowing where you're getting that restricted movement, you can then start to work out where in the gait cycle that's going to cause an issue.
Just in case anyone doesn't know, can you just explain what a gait analysis is?
Yes, the gait analysis, very simply, the gait means your walking pattern, basically. And so I know everyone thinks of like the gait on your like garden door and stuff.
That's why I thought I'd bring it up.
But actually, so if I prefer to call it your walking pattern. So we need to analyse your walking pattern and look at from the moment you put your heel down the ground, so it's striking up down to the ground, all the way through where it becomes nice and flat, all the way to when you push off on your big toe as you move off. And that's your gait cycle.
So, I mean, I've had it done. I'm talking a lot about myself today, a lot of self-referencing here today. Sorry about that.
I think it's quite good because then it actually gives people an idea of how it all works, because when you've got someone going, oh, yeah, I get that back pain. Why is that kind of coming about?
Yes, I've had like back in the day when I used to briefly enjoy running, I would do like a gait analysis to get like a new set of trainers, and I just had that done in like a sports shop. I'm not sure if they still do that these days.
Can I put a word of warning about sports shops?
Please do.
So it's probably not a very popular view, but in a sports shop, it's the idea of going on this like lovely machine and they look and go, oh yeah, you've got pronated arch, or I've seen. They haven't got the years of training that a podiatrist has in terms of that. And also I always say like scans are as good as an IKEA product. The product's great. It's the user that causes the issue. Like with an IKEA product, you make up the cupboard and then you've missed out the screws and everything or something like that. That's what happens. And in a running shop and places where you go to the gym and you see those, we'll do a gait scan on you.
Yeah.
In the nicest way, you cannot, from a gait scan, understand the full body and the complexities of how that moves. Because, for example, you may have a pronating foot, so i.e. you're getting that flattened arch. Absolutely. But you have to take genetics into account. So depending on your heritage, that has a huge impact. So the Afro-Caribbean population, African population, tend to have a much more lower arch. So if you were then to suddenly go, we've got low arches, you need to have an insole, what you're actually doing is to force them into a high arch position, which their body cannot take. And it's actually going to create issues such as the back problem, because that's not how they're genetically predisposed to be. So that's one example. Another example is, say you've had an ankle injury, and there's a very key bone called the talus. And I describe it as like, the Dyson Hoover with a ball. And you move as the foot of the Dyson moves around, and the ball moves to allow the footbed to move around and everything. That Dyson ball can get injured really easily, and it can slip out of place, particularly, and only by a small millimetre or two, and the facets of it will slip out of place on the foot, and it then gets jarred. So can you imagine if that Dyson ball in your Dyson has just slipped out slightly, you won't be able to manoeuvre the Dyson, which is the upright part, which is your leg, the footbed is your foot. That happens on there. So you'll then do this gait analysis cycle, and they'll go, oh yeah, you're not pronating properly, or you're overly supinating because that talus bone has come out slightly, which they don't know about, but that's what the reason. And it will stop you being able to move the foot from side to side and up and down. And as it's not letting you do that, it's going, oh, you need an orthotic, but actually you still need to do the actual checking the joint itself to see if that's the cause, not just by looking at the scan. Does that make sense?
It does. It does. Right. So, well, go to a podiatrist for a gait analysis now, and not a sport shop.
I would go to a podiatrist first and then go to the running shop, because you'll get far more information. You get everything assessed. If there is something, quite a few podiatrists are now starting to do foot mobilizations and things as well, which will again help improve your joints. In our clinic, we do, and it works fantastically.
So when should someone go and see a podiatrist? What's the elements that they should like? Oh, I've got this, I should go. What are some of those?
So I kind of compare podiatrists like dentists. You should go anyway, regardless of whether you've got arthritis or not, and we all go to have our teeth checked, our eyes checked. It should be the same for your feet, because there are so many things that can go wrong. And also, it's the one part of the body you can't replace. You can replace implants for your teeth and things, but your feet, they are so complex. There's not a transplant thing that you could do. But particularly when you've just been diagnosed, or even if you haven't been diagnosed and you're starting to get those foot pains and things, or the doctor just said, oh, it might be a bit of arthritis, just natural wear and tear, just get on with it, see a podiatrist. But even if you're not seeing them at the beginning of your journey, even throughout your journey, you should go and visit a podiatrist, because again, things like no one explains to you with some of these conditions like the psoriasis, arthritis, the rheumatoid arthritis, the drugs that they're on can also have an impact on the foot. So in terms of the vascular, in terms of the blood circulation, and the things that affects the neurology side of things, so your nerve sensation, and also in terms of your skin and nails. So again, you should always have it checked. And I recommend at least see the podiatrist once a year, have an MOT done, get yourself checked. And again, we're picking up not just the arthritis things, we're picking up other conditions that can also relate with the arthritis, such as diabetes, if there's any anemias going on, any cancer. So again, it's not when you see us, you're seeing us for a whole we're looking at everything, not just the condition you've come in with.
I think that's something probably a lot of people don't know, is that they just assume you're just going to look at the foot, that's it. But there's so much more to it, as you've explained.
There's so much more to it.
So how do people get an appointment? How can the average person go and see a podiatrist?
So there's two ways. You can try and get referred by the NHS. And as we know with the NHS at the moment, it's a bit hit and miss depending on your postcode and actually whether you get referred and what they can offer or what treatments are available. So you've got the NHS route, but you also have the self-referral where you can just go on Google, or what I recommend is you actually go on the Royal College of Podiatrists website or the Institute of Podiatrists website, where they've got a list of podiatrists on there, and find a podiatrist there. But I also recommend, even if you do both, you have to make sure that one thing they have to make sure is that they're HCPC registered, so the Health Professions Council. Make sure they're registered, they've got registration. Everyone that has to practice a podiatrist has got a registration number. And again, you can check it on their HPC websites as well. And also the other key thing that I think is really important for patients, ask for word of mouth. So don't just go rely on Dr. Google and go, here you go. And also look at reviews. And also say you have got particular arthritis, ring up the clinic and go, are you familiar with this condition? How would you treat it? There's no harm in a question going, do you treat it? Are you familiar with it? Because podiatrists specialise in a number of areas. So in our area, we specialise with the cancer and the pain management side of things as well. So I'm okay with it, but some podiatrists might just do routine, or some podiatrists might just do musculoskeletal. So find the podiatrist that fits you.
Absolutely, that's good advice. Good advice. So, what can people do just for their overall foot health? Like, because we've mentioned, you like a more holistic approach and so on. So, what are some of the things that people can do to keep their foot health good?
Right. So, in terms of mobility, just keeping the nails short, but not cutting down the sides of the nails. So, when patients who are struggling with mobility issues, what I get them to get a long foot file and use that to file their nails rather than trying to cut them, because actually you can't do any damage by filing, but it keeps it down. Because one of the other areas is if your nails get too long, they start to dig in, your feet start to claw up because it's painful, and then you're more likely to fall. And already we know with these patients that balance can be an issue already. So we just want to minimise that falls risk happening. So that's one thing. Moisturising regularly as well. So not only does that mean that you're checking your feet regularly for any cuts or anything, because especially if your immune system's compromised, you don't want any of those cuts becoming infected. But again, you start to notice if things don't feel right. So by using the cream, you're massaging the area. So you might notice that all that toe's starting to feel a bit numb as well. So again, it just gives you a chance of being really aware of what's going on with your feet. In terms of what to do, actually keeping moving, gentle movement is actually really good. Things like walking on the sand, those kind of things are actually quite useful when you're on holiday, because again, it's that soft movement. Avoid things like high impact exercises, so such as running on a treadmill or running on hard ground. That kind of thing can also cause, you want something a bit more gentle on the foot in terms of impact going on. I also recommend to my patients things like Tai Chi and yoga, because again, it improves balance, particularly Tai Chi. The reason why I like Tai Chi more is because it's that slow balance movement. You're standing, doing all the movements, but also when you're doing these slow movements, you're using your own body weight to actually strengthen the muscle. So it's called eccentric training. And that again helps build the muscles, the tendons without causing that damage. And it's a very gentle exercise. So that's really useful.
I remember because I'm a big fan of yoga and I've been doing it since I had, again, back injury, like years and years ago, started it then. And one of the first things I noticed when I started doing it was how weak my foot muscles were, because it's something I'd never thought of from being like a regular gym guy at the time, who trained in trainers all the time.
Yeah.
And then when I started doing it, the muscles in my feet are so sore afterwards because they're just not used to being used like that. And it's really interesting to find out that you have not been using all these muscles in your feet properly this whole time.
And I mean, they're your core muscles, that's the first thing. They keep your body upright 24/7. So the other thing is footwear. Biggie on the footwear. Making sure good shoes with a straight sole or straight last. So draw around your foot on a piece of paper and cut it out, and then place that underneath the sole of your shoe that you're wearing. If your foot is starting to stick out on any parts of the shoe, you know that shoe's not going to be right for you. That's a really simple, easy way to find comfortable shoes.
I like that. That's so simple and ingenious. I never even thought about it.
So, and you can cut out your little so the only other thing I say is when you are drawing around your foot on a piece of paper, just make sure you put your knee over your foot so you're actually flattening on the piece of paper, because your foot will spread slightly, and then draw around it and just cut it out. And you can put that in your wallet. And then when you're at the shoe shop, before you even, have to take out, because also it's difficult trying to find shoes and then taking your shoe off to put a new one on. You've just got your little piece of paper, place it over. The only other thing you need to think about is that sole of the shoe has a 1 centimetre rim around it, because that's where the upper leather or fabric material attaches to the sole. So make sure that you've incorporated that, because what sometimes we see, particularly with the trainers these days, you start to see this like bumpy part on the heel, like they built up the heel around the shoe, but actually that's not where your heel is sitting. So just be aware of the designs of some of the trainers, where they look like they've built out the sole, but actually the footbed inside is not great. And the other thing is, because the good thing about trainers is they've got a removable insole inside that shoe. So you could just compare your removable insole that's inside that shoe with your template of your cut out foot.
That's a good one as well. I did actually want to ask you about, because I see so much stuff these days like popping up in all my various feeds and so on about barefoot shoes, and they seem to be increasing. Okay, they're good, are they?
They are good. The only thing with barefoot shoes is some of them have a very thin sole. And we live in a climate where we have uneven ground, and things like, when you're standing at a traffic light, you'll you use some of those bubbly bits of pavement, you'll feel everything under it. And that can be quite painful, especially if you've got arthritis in your foot.
Yeah, that's where I was going to go with that. So this is actually mostly satisfied my curiosity, actually, to be honest. What's your opinion on Crocs? They're everywhere, and I want to know what a professional's opinion is on these.
I think if you're going down to the beach, absolutely brilliant, or going up at the back of the garden. If you're every day going shopping wearing, no, because you do slip around in them. And if you're slipping around in them, you can't hold your foot in position. If you can't hold your foot in position, you're going to start to scrunch up your toes, start to tense up those muscles. So again, you're making your foot much more rigid to try and stay inside the shoe. You can't do that shock absorption that you need to get around, which then starts to cause, in my personal opinion, damage to the joints more.
Okay, so a friend of mine was out with him the other day and initiated what he called sport mode, apparently, which is like they've got that strap that goes over the top of them, and you can hook it to the back of your heel, and apparently that's sport mode.
Right.
What sport
So
you do in
sport
Crocs, I
mode,
don't know.
yeah. So a good thing about so we always recommend that a shoe has an ankle strap, and the reason why is you don't want your foot moving around. So this whole sport mode means, oh, actually, we're trying to now grip your ankle so you're not slipping around as much as you normally are in that Croc. And if anyone has seen a Croc, I don't know who's got wide enough feet, but you don't see this like slipping around. Like you can get pretty much your fingers inside the shoe. So activating sport mode, meaning that, oh, it doesn't quite fling off as you're walking along, is not great because you're still scrunching it all up.
Yeah, I suppose for people with like very swollen feet or something like that, is there
So for them, yeah, I mean, the Croc might work, for hot weather and they're getting swollen feet, absolutely. But again, not for your everyday walking. I'd recommend like a hiking trainer or something that's got a Velcro bit at the front on the forefoot, and also one like a Velcro adjustable strap on the ankle. And also, again, for those swollen feet, things like DB shoes have really good sandals for swollen feet, and they come in different depths. Because again, when you're swelling, we forget it's the depth of the shoe that gets affected. Everyone thinks it's the width, it's not, it's the depth. Cozy Feet are another brand I know that do, and there's a few other brands, but particularly Cozy Feet and DB are for those really swollen patients, especially ones that have also got some lymphedema as well. So again, just part and parcel of some of these conditions or co-conditions that work together.
Okay, great. So there are better ones available for that type of thing than Crocs.
Yeah,
Just, yeah,
rather
there's
than
more,
Crocs.
yeah. Okay, good to know. Good to know. I will let my friend know. Okay, so when it comes to surgery, then, because obviously some people are going to have surgery on their feet. Can you talk a little bit about surgery, like your foot and arthritis as well?
Yeah. So there's two types. There's two surgeons. You've got the orthopedics, so people go to, but you've also got podiatric surgeons. So podiatric surgeons, I think, in my opinion, are far better because they've had to do podiatry. So they have an even bigger depth of knowledge in terms of the foot and how it works and the mechanics of it and everything else like that. So finding a podiatric surgeon is better. Surgery is, again, some of the surgeries are really successful, but again, it depends on what's going on. So if it's just kind of a deformity that you're not getting as much pain and you're not struggling with, it might be that you don't do surgery. But if you are getting lots of pain and you can't get shoes on, you can't get out, then obviously surgery is the way to go. And again, do your research with the surgeons, ask questions, ask what the recovery time is, ask what the success rate is with that surgeon, how successful on a bunion or operation do you get? Say you're a young person, quite active, and you've got the rest of your life, certain bunion surgeries might not be suitable because they actually make you more rigid, and actually you've got another 40, 50 years running around and being active. So choosing the right surgeon who's going to choose the right surgical technique for that toe operation or bunion operation or whatever it is, or if it's an ankle operation, just getting as much information as possible. And again, how long you're off your feet for and what the recovery is, what it looks like, and also what the rehab looks like. Because I think everyone forgets about the rehab is really key. It's all very well once they fix the area in place, but you're still learning to walk again because your body isn't used to that foot position.
Absolutely. I mean, do you think a prehab is also something that needs to be done as well?
I do. I think there should be a lot more prehab and whether the patient is suitable rather than just looking at the scan going, oh, yeah, it's wonky or whatever. Yes. Oh, you're in pain. Is that patient able to do the rehab? Is that patient going to be able to change their footwear? Is that patient able to do what they're doing now? I think is really important.
So, last question then. If you could tell us about any new techniques available in the MSK field, because I believe this is something you're involved in.
Yeah. So I use a multiple area technique. So particularly we use anatomy and motion, which you can look into, but basically it breaks down the gait cycle all the way from the head down to the toe, and it breaks down each joint and what each joint should be doing in that gait cycle. So you're looking at it in even more detail than before. The other thing that's really, and then so with the anatomy motion, we'll work it out. I will then mobilize the foot get that moving and encouraging that, but also get other areas moving in the body that might not be, and getting that body aware of it. And then we'll give you exercises to strengthen. These exercises literally are, you only get given 2 to 3 exercises, and they last maximum 5 minutes, which again, compared to a physio exercise where you're doing for half an hour, or you get given a list of that physio exercise, right? And they go, just try whichever and just push harder. This one is all about, in terms of our theory with anatomy motion, is bones act, muscles react, right? So if the bone's not moving correctly, the muscle's going to react either negatively or positively. So if you can get your bones to load properly, your muscles will start to also improve. And it works fantastically well. It was also shown on Dr. Chatterjee in the House. So there was an episode about someone who had back pain in there. And so you can see there's clips of it on BBC iPlayer and things as well. The other one that I use fantastically is called adaptable polarity. So that uses craniosacral techniques, but it also works at tapping into the neurofunction and actually getting the body to calm down. So that nerve sensation calming down, improving blood flow. Again, a bit like cranial osteopathy, which like moves the bones gently. There's no clicking involved, but just slowly calms the whole body down. The other area I use is kinesiology. So kinesiology looks at the body completely holistically. So it focuses on the structure. So there's particular areas that we can use to manipulate to make sure the body's working correctly. We look at the emotional state. So again, things like heightened emotion and anxiety can actually have a huge negative impact on disease. We react with the disease as well. So we work on the emotion side. We also work on nutrition, which actually is another area which I think we need to explore a lot more with arthritis, because it makes a huge difference. And then we obviously look at the, so it's known as the electrical side, but the acupuncture meridians. So we look at all things like, in acupuncture terms, in terms of the water and the metal and making sure that's all balanced in terms of acupressure points. So I use all 4 together. And I always used to use acupuncture as well, which I find works fantastically, especially in getting some relief in some of these conditions. It really does. But particularly with the kinesiology aspect to it, it just is amazing in how it gets the body moving. So we've got that. And the other one that I think is really important that no one really touches on is fascial releasing.
Absolutely.
Because a lot of these, when you've got joint inflammation and joint restrictions, a lot of it's to do with the fascia. So the muscles are doing fine, but it's the fascia that's coating around these muscles that are really, really tight and restricted, like a spider web, and they get more and more knotted. And the more and more knotted they get, the more restriction you're going to get. And also they affect things like the blood flow, getting to the area. So getting good fascial release, I think, is really, really important for any patient with any of the types of arthritis, because it really does make such a difference. Also, when you're doing fascial release, what you're doing, and foot mobilization, is you're actually stimulating something called hyaluronic acid. So we see it in the cosmetic products, right? Everyone's going hyaluronic acid for face creams to make you nice and plump. But actually, hyaluronic acid is much more important than just making your face look good and plump skin. It's actually the liquid that allows the cell to glide against each other. So any cell, so bone cells against muscle cells, against tendon cells, against fascia. So if these aren't gliding between each other, you know you're going to get restrictions happening. And so that hyaluronic acid and that stimulation of hyaluronic acid is really, really important. And the other thing is, just on a side like this, making sure my patients are drinking enough water.
It's always such a neglected, but such a simple one.
Yeah, everyone doesn't talk about it. And just good, pure water is really, really key, particularly with the lower back pains. Making sure you're getting at least 2 litres of water in, particularly in the kinesiology terms. We find if you're dehydrated, the psoas muscle, which inserts into the lower back, goes through and inserts into the femur. A lot of patients, we just increase their water, actually helps reduce their back pain, because that psoas muscle gets really dehydrated and starts to work properly. And again, doesn't give any drugs, and it's perfectly good for you.
Okay, great. So if you'd like any more information on all the topics we've covered today and anything we've been talking about, please do visit our website. There's a link to that in the episode description below. You can also send us an email if you have any questions or future topic suggestions, anything at all, and the address is down there also. And please don't forget to like, subscribe, follow, hit the alert bell, just to make sure you don't miss any upcoming episodes. And, please do feel free to give us a favourable rating if you have enjoyed this podcast as well. So thank you very much, Afni. I really appreciate your time today.
Yeah, no, thank you for having me.
And thank you everyone for listening. Bye-bye, everyone.